Welcome. Hi. So it's a very surreal experience, first of all, speaking to a tiny group, knowing there's like another group watching. So I wanted to give this talk because I had an interesting case in September that was an OB case, which, as you guys all know, is my thing. So I told Chris I'd give the talk, but as the time for the talk grew near, I realized that there was more than, I didn't just want to present the case. I also wanted to just thank everybody for, like, my good experience on OB. You know, I was the first woman in the group to have a kid well in the group and take maternity leave, and then I did it again with Lily, first Michael, then Lily, and kids would sometimes come and visit me in the OB call room, and picture up there of me and the 3 other Susans at the old Cal campus. And the bottom right is a screenshot from one of my last Zoom talks. Every other month for the last 23 years, I've been doing a pain relief options in labor, ask the anesthesiologist talk for expectant mothers through Newborn Connections. I've been volunteering to teach the class so women can take it for free to make sure that it's not just like the childbirth educators and doulas giving all the information about epidurals and other medication options in labor. So I wanted to thank you guys all because it's been a fantastic experience, and assuming that everything goes okay with my daughter, who it's not exactly clear that it will because she's got some pretty serious health issues, assuming she can go back to school and stay, come late January, I'll actually be moving down to Mountain View to live with my very patient beloved of the last 8 years, Moan Flowerton, and because it is a 45 to hour-and-a-half commute back up here, depending on the time of day, I'll be working down there in Mountain View. It's a leave of absence for the next year, assuming I don't screw things up with the relationship, which isn't a given I'm over to with marriages, but fingers crossed. But it really has been absolutely wonderful. I absolutely love being a caregiver. I love the work I do on OB and in the general OR, and I love working in this group. I'm very proud to be a member of our anesthesia group because I think we provide really good care and we're really good people, and I really love you guys. So there's that. All right, but what I really want to talk about today is post-dural puncture headaches, which kind of gives away what the case is, right? It's a clinical presentation with some lessons for communication thrown in, because you know I'm into the touchy-feely stuff, right? Okay. So I'm going to talk about post-dural puncture headaches and all that follow. We're going to start off with the case introduction. Then I'm going to talk about the an incidence of post-dural puncture headaches in obstetric anesthesia practice, the characteristics of post-dural puncture headache, and their management. Then we're going to go back and talk about the case some more. We're going to talk about some interesting and concerning emerging data about post-dural puncture headaches clinical outcomes. We'll talk about how the case finished up, talk some more about postpartum headaches. Then we're going to talk a little bit about how we deal with the harmed patient when we screw up and they are harmed because of our actions. And finally, we'll end with a little proposal of mine for some potential practice improvement. Okay. So, the wet tap, you know, you feel terrible, but not as bad as the patient will. You know that at the time. So she was a very anxious person who explained to me before I even started that she had a traumatic spinal tap, I guess, in her past. She was very anxious about needles. She was also overwhelmed with just how labor was. I think she had planned to go medication-free, and here she was in her labor feeling like she needed an epidural, could not sit down. And one of those folks, when you go in no, they can't possibly sit down. And then with the very first contraction, after they've been sitting down, they stand up and they sit back down again. And I'm prepping all my stuff, and she's sitting down, and there's some folks who have a way of being miserable that, at least for me, makes me miserable, and I feel awful for them. And she had that talent. And so I was, this is a periodicity conversation that I had with Marie afterwards, and I think that actually contributed to the wet tap in some ways. It's not that she moved, but she was so inconsolable that once I was seated in her back, when I was moving my glass syringe over to attach it to do fluid saline loss of resistance, the back end of the plunger dumped out, right? And so now I had an empty glass syringe. And she was so inconsolable. She was asking, one of those who was asking every other minute, "Are you done yet? Are you done yet? Are we done yet?" That I just thought, okay, screw it. I'll just do air loss resistance. I did it with oscillating air loss resistance, and I got loss of resistance at 5.5 centimeters, and then the plunger just filled right back up at me, filled with CSF, fast. So I instantly pulled back, I think I pushed the saline back in, then but not saline, CSF back in, then pulled back, and then, no more came out. So now I was at 5 centimeters. So I pulled back a full 0.5 centimeter, 5 millimeters, which, when we're talking about approaching to the epidural space, that's like a mile, right? So was I even still in the epidural space? So I attach, now I get some saline. Goes in beautifully. Okay, I'm in the epidural space. All right. Have a hole in the dura. Normally, I load with 20 mLs of the saline solution, of the epidural infusion solution, which is like 20 milligrams of bupivacaine, right, and 40 micrograms of fentanyl. I wasn't going to do that with the hole in the dura, so I think I put in like 15 or something. I put it in, and it went in beautifully. And then I threaded in the catheter and got a very reassuring paresthesia, letting me know I, was in the epidural space. Pulled it back to 8 centimeters. Honestly, I don't normally pull back a catheter that far. Again, it was a little bit of probably anxiety, and it pulled back a little further than I meant it to. And I thought, okay, well, hopefully this will still work. And it did. She had a beautiful epidural for her labor. Let's draw back now and step away from the case and talk about post-dural puncture headaches. So a post-dural puncture headache is characterized as a headache that occurs within 5 days of a known dural puncture, and the dural puncture could include something like a laminectomy, with a dural tear at the procedure. But in our case, of course, it's an epidural for pain relief in labor. The headache gets worse within 15 minutes of being upright, and it gets better within 15 minutes of being supine. It also might be accompanied by nausea or a stiff neck, photophobia, blurred or double vision, tinnitus, vertigo, hearing loss, or hyperacusis, that is to say, extra sensitivity to sounds. And with 4 million women delivering a year, and something like 70% of them getting labor epidurals nationally, assuming an accidental dural puncture rate of 1%, we're talking about just under 30,000 accidental dural punctures a year, of whom 60 to 80% are going to go on to develop a post-dural puncture headache. So we're still talking about over 20,000 post-dural puncture headaches every year. All right, so let's talk a little bit about the pathophysiology of why you get the headache, just to review. So you're losing CSF, as we all know, through that 18 to 17 gauge Chewy hole or Husted hole in the dura. A distinct difference from the 24 to 25 gauge hole we intentionally make with a spinal introducer when we do a spinal anesthetic. And so with the loss of CSF through that hole exceeding the production of CSF by the choroid plexus in the brain, even though the choroid plexus every 24 hours is secreting and reabsorbing a liter of fluid every 24 hours, the leak through the hole exceeds that, and in time, the level of CSF that the brain floats upon actually decreases, and the brain physically sags because of the intracranial hypotension. And when it sags, the traction on very sensitive pain structures like the meninges, blood vessels, particularly the veins and sagittal sinuses, the cranial nerves, they get a little traction too, even the upper cervical nerves. And there's also pain probably from the compensatory vasodilation that takes place that the brain has in response to this shrinking pressure. MRIs of people with post-dural puncture headaches and CSF leaks show, engorged venous sinuses, enhanced meninges, and the pituitary gland particularly enlarged because of its highly vascular nature. And also maneuvers that happen to increase cranial venous pressure, like coughing, laughing, or a Valsalva maneuver, that makes the headache much worse. All right, so that's how it gets so miserable. So pretty recently, actually this August, a big group put out a consensus practice guidelines on post-dural puncture headaches from a multi-society international working group. And it was led by the American Society for Regional Anesthesia and Pain Medicine. It included all these other societies, the European Society, the SOAP, Society for Obstetric Anesthesia and Perinatology, the English SOAP, Obstetric Anesthetist Association, the American Society for Spine Radiology, and the American Interventional Headache Society. So basically, everyone you're going to want commenting on this entity got together to review everything that was known about it, to give us all advice as to what to do. All right, and so what they did was they agreed upon 11 questions that they thought were the most essential questions to ask about how do you deal with post-dural puncture headaches. And they split up into groups and went through all the literature available. Within the groups, they determined the level of quality of the literature and thereby the level of strength of recommendations they could make and what recommendations to make. And they had this whole elaborate voting process where they did eventually have to have a consensus on everything they recommended. All right, so, and you can imagine, needing a consensus on everything, there was a lot of stuff they couldn't say one way or the other. For instance, what measures can be used to prevent a headache after you've actually already had a dural puncture? A lot of us have talked about, I remember I learned about in residency, if you get a post-dural puncture, well, if you get a dural puncture putting in a labor epidural, maybe you can thread the catheter through the hole in the dura and have an intrathecal catheter, and perhaps the irritation of the catheter in the dura will cause a greater inflammatory response, and you'll get turns out, the committee couldn't find anything to support that recommendation. Not to recommend against it either, but there was nothing they could say that could support that idea. They said but they did comment that the catheter could be used for pain relief and anesthesia, but that of course you need to consider the risks of actually having an intrathecal catheter during labor, where there's risk of infection, direct access to the intrathecal space, and also the risk of, somebody injecting it as though it weren't an intrathecal catheter. All right. So what about a prophylactic epidural blood patch, giving people doing a blood patch before the person even gets the headache? Couldn't recommend that. Couldn't recommend injecting anything else into the space, including saline, to just try and buoy up the space, or any particular systemic drug administration. But they were able to make a moderately strong recommendation, actually, against bed rest, which is interesting because I know classically in other areas of medicine where they do lumbar punctures and expect the risk of a post-dural puncture headache, they'll have people lie flat for 6 hours or 12 hours as though that's going to prevent it somehow. And I think the reason they make a recommendation against it in the context of obstetrics in particular is, you're dealing with folks who are hypercoagulable. You tell them then to be on strict bed rest for what, 24, 48, 72 hours? To set up for a DVT. Okay. So what conservative measures should be used to treat a post-dural puncture headache? Now that you've got the headache, what should we do? If you're not going to do a blood patch, what are these conservative measures that people talk about? Hydration, they support. Caffeine in the first 24 hours, they actually support using caffeine up to 900 milligrams in the first 24 hours, although only 200 to 300 if you're breastfeeding, which unfortunately covers, the majority of our patients. They recommend acetaminophen and NSAIDs for all, unless it's for some reason contraindicated. They even recommend and support the idea of using opiate analgesia in the short term, though not the long term, if acetaminophen and NSAIDs are inadequate to help people get over the first few days if the headache is going to heal itself. And likewise, bed rest for symptomatic temporary relief, though not as the idea of to keep it permanently at bay. They had insufficient evidence to recommend any of those listed systemic medications, hydrocortisone, theophylline, the sumatriptan stuff, ACTH, or its synthetic analog, cosintropin, neostigmine or atropine, which personally I'd never heard of giving in response to a post-dural puncture headache. Pyritramine is it's a narcotic. Methadone or gabapentin. Clever idea, gabapentin, but no, that doesn't work either. And they had a low-strength recommendation, once again, against abdominal binders. And I imagine this goes along with that idea of not raising central cerebral venous pressure. All right, the question about when and how a blood patch should be performed. They recommend that a blood patch should be performed when post-dural puncture headache isn't helped by conservative treatment and it's impairing the activities of daily living, which for the newborn, in the context of a mother with a newborn, involves, bonding with the newborn, caring for the newborn, nursing. Or they say when the patient has neurologic symptoms like hearing loss or other cranial neuropathies, they recommend that the patch not be done until 48 hours after the dural puncture, if possible, unless, of course, it's impairing with the person's activities of daily living, or they have some of those other neurologic symptoms listed above. But if you do need to do the puncture, if you do need to do the patch 48 hours before, or rather before the 48 hours have passed, then you need to at least counsel the patient that there might be an increased need for a possible repeat patch. Obviously, they recommend injecting aseptically obtained autologous blood, not to inject poorly technique sterile blood injected, and also to inject the blood slowly into the epidural space and to go at one interspace below or at the level of where the dural puncture was, if you know where it was, which in most cases you do. And they also recommend that if it's a blood patch being done after a CSF leak from a laminectomy, you might want to consider actually using fluoroscopy and use a transforaminal approach. Or if you've had a failed attempt at doing a regular intralaminar epidural blood patch, either because of technical difficulties or because you just couldn't get it didn't work at all and you're even concerned maybe you weren't in the epidural space. After all, some of these occurred in someone who was a very difficult epidural, and so it may be that accessing the space is quite difficult. They say that informed consent should include the potential for needing a repeat dural puncture and backache and neurologic complications. This was actually in the consensus guidelines, neurologic complications. To me, that's a really garbage disclaimer. They don't specify. If I were a patient, I would immediately ask, well, what neurologic complications and how common and how serious, right? So I don't have that. I don't hold that particular phrase in high regard. All right. One should assure the patient that they can still get good epidural anesthesia in the future after an epidural blood patch. I remember actually being taught, or rather the concern being expressed in training, that perhaps we are scarring the epidural space when we do an epidural blood patch and ruining this person's ability to get future epidural anesthetics. So it was that was encouraging to read. And furthermore, they make a recommendation that you need to follow up with the patient until their symptoms resolve. All right, well, what are the possible long-term complications of a post-dural puncture headache? Chronic headache, chronic neck and back pain, depression. We could all look at those and say, well, is it really the post-dural puncture headache, or is there something else going on? Cranial nerve palsies, if you can imagine a traction that goes unchecked. If a traction on the structures go unchecked and there's severe intracranial hypotension over weeks to months, you can actually get subdural hemorrhage. You can get cerebral venous sinus thromboses, because as you recall, the venous sinuses, they dilate and more blood gets in them, and so with more blood and more stasis, you, in the hypercoagulable situation of still the declining hormonal milieu of pregnancy, you're at higher risk for thrombosis. All right, so given that these are some serious long-term complications, what are our implications then for patient follow-up? We need to inform patients, actually, about the long-term complications of a post-dural puncture headache prior to discharge. I think in the past we've reassured folks, oh, it's a headache, it'll go away. If it doesn't go away, come in, you can get a blood patch, or you can just wait and let it go away on its own. We actually should probably tell them, in fact, we need to tell them that if it doesn't go away after a week, after 2 weeks, they really do need to check back in with us because they are at risk for some serious complications in the long term. It's small chance, but they're serious enough that we need to follow up. And furthermore, they make the recommendations that the practitioner responsible for the dural puncture needs to take responsibility for communication, follow-up, and coordination of any further evaluation by other specialists. Because if you think about it, particularly on labor and delivery, we are doing a procedure for pain relief, and then they're going back to their OB silo of care, where the OBs aren't experts on post-dural puncture headaches any more than, we're experts on shoulder dystocias, right? So they need someone that can be their contact point and knowledge point of who to recruit help for them should they need it. All right. So after she delivered, what did I do? Well, after she delivered, first of all, that's when I finally told her what happened, right? After she delivered, after she'd been nursing for a while, after the golden hour, through a later discussion that she called it, I went and told her about the CSF leak and how she was at risk for getting a headache afterwards, and that since I knew the catheter was in the epidural space, and mind you, I hadn't read all of those guidelines that had come out that August, because this is September, and I actually, hadn't. I was going to leave the catheter in place for now so that, if she did develop a headache in the next couple hours, maybe I could just inject blood through that catheter to help with the headache, and explained a little bit about how the blood would fix the headache or how it could. And then, she was going to go upstairs and I was going to follow. And this was just after midnight. She delivered, late in the evening. Okay. Seemed like a good idea at the time. Why did I think that was a good idea? Well, of course, after getting the wet tap, which I was crushed about, it was my first in like 10 years. The last one I had when Joe Durrett was still alive, I remember, because we talked about it. I came across this study that was published in 2014, where they had 116 women that they recruited over a period of 8 years, from 1997 to 2005, who had dural puncture after an epidural labor attempt. And they randomized the women to 60 of them to get epidural blood patches, and what turned out, they studied to be only 49 to the conservative management arm. And it was intended to be a well-designed study. They actually had a sham blood patch with saline through the epidural catheter for those that were in the conservative management segment. Everybody kept their epidural catheter post-delivery for a couple of hours. They did the the prophylactic blood patch for those that were in that wing, and those that weren't, they did the saline injection, and then they withdrew the catheters, and then followed the women. It turned out of the 60 that got the prophylactic epidural blood patch, only 11 went on to get a headache, 49 had no headache. I thought, that's great. This is worth trying, What have I got to lose? It's just injecting some blood through the catheter. So I decided that's in the back of my mind. That's what I was going to do if she did get a headache. Okay. So yeah, of course she got a headache. Remember that fluid shooting back at me when I got into the space. So 3 hours after delivery, she was having a headache, neck ache. Was worse when she was sitting. It was better when she was lying down. So we discussed again the principle of the epidural blood patch and how it would work and how the blood could act to seal the hole. And she was in favor of doing it through the catheter before pulling it, understanding that, and I explained to her, she may need a real blood patch, a more formal one, through the skin, poking her again to get into the epidural space later on if this one didn't fully take. And I checked, the site of her epidural catheter insertion was clean, the dressing was intact, so I thought this was a reasonable thing to do to inject a a potential media type thing like blood through it into the epidural space. So I injected the catheter, and by the way, injecting 20 mLs of blood through an epidural catheter is really hard. Of course, I took off the filter. I usually have the filter going when I have the infusion going for extra protection, but of course I took off the filter for the blood because there's no way I was going to get the filter through the blood through the filter rather. So afterwards, we talked about what not to do, and as shown here in the side of the slide, I gave her, this is a text message I sent to her. I always give people my phone number. I get theirs, and I send them in a text message what the instructions are not to do, right? You've got to no lifting anything heavier than your baby, no jumping, no pushing anything or pulling anything with effort, don't strain to poop. I'm always in debate as to how to phrase that, but I want to be clear. I tell them to take stool softeners every day for the next 2 weeks because for those of you who haven't breastfed after delivering, you're constipated. It takes so much liquid to breastfeed that even if you're drinking 2 to 3 liters of fluid a day, you need to take stool softeners. And I told her to call me anytime with questions. And then I remembered, because she was telling me, she was asking about the different things she could do. She's a big stretcher and yoga person. She was asking about like downward dog and explained no, none of that. So she agreed. Okay. Now let's go back now and talk again about some of those possible long-term complications of a post-dural puncture headache. I recently attended the ASA conference here in San Francisco, and every year they have this discussion about what the most recent relevant obstetric anesthesia articles are that might change practice. And one of them was a scoping review article about chronic headache related to post-dural puncture headaches. This study looked at 32 publications reporting headache that lasted of a duration of greater than 1 month after a known neuraxial procedure, be it a labor epidural or other neuraxial procedures, like all of those spinal taps in the ER where they're using, 20-gauge Quincke needles. And they examined 5 prospective studies, 7 retrospective studies, and 20 case reports, because really that's all that was out there, right? So they did a very formal process of looking at the risk of bias assessment process for dealing with the reports that are just like prospective and retrospective studies and case reports. They're not randomized trials. And with that, with their data extraction, they did the best analysis they could. But what they came out with was pretty concerning. Chronic headache after an accidental dural puncture is not uncommon. 38% of those who had an accidental dural puncture still have a report of chronic headache 6 months later. Now, it's also impressive that 16% of those who didn't have a dural puncture were reporting a chronic headache 6 months later. So, okay, maybe, chronic headache is pretty common, and I can imagine chronic headache is pretty common in the OB population with all of the stresses of caring for a newborn. But still, that's twice the risk of having a chronic headache if you've got a post-dural puncture, an accidental dural puncture, rather. Did they find that epidural blood patch lowered the risk of a chronic headache? Actually, there wasn't any sign that it did. The results were pretty mixed. And also very concerning was the fact that for those who actually went on to develop the chronic headache, 91% of them were asymptomatic at discharge. So we're doing labor epidurals, causing the occasional, having the accidental, dural puncture occasionally, causing a post-dural puncture headache, patching that headache while the patient is still here in the hospital. It works, sending them home, feeling, good about ourselves. They're feeling good, the headache's gone. There's no guarantee they're not going to get a chronic headache after that. And we don't really understand why it happens. Is there any particular patient risk factor or any particular optimal treatment for chronic headaches? It's not really known. So Why do post-dural puncture headaches become chronic headaches? Well, in the roughly 25 to 30% of those with chronic headaches who have a postural component to their headache, it's thought that there's probably still a continued CSF leak ongoing with continued intracranial hypotension. And in fact, radiologic studies that investigate these folks show, in some cases actually a ventral leak. So, that means the epidural introducer or spinal needle or whatever went in all the way through and through to the other side of the dura, right? Making a leak there as well that continued. And so that our regular epidural blood patch from the posterior approach probably wouldn't patch that, right? Sometimes it's a CSF fistula that shows up, pseudomeningeal, even a CSF venous fistula they found in some of the cases. And they thought that for those with a negative radiologic study, honestly, it likely reflects a false negative, that there's probably some small, slow, intermittent leak that didn't show, but that's what's causing the postural component. But what about those 70 to 75% of folks that don't have a postural component? Why do they have a continued chronic headache if they have no leak? Well, perhaps during the initial period of intracranial hypotension, there's actually, with that traction of those sensitive structures on the brain, you get a sensitization of the trigeminal cervical complex at the time. And so you end up with setting up a system of pain wiring, like a complex kind of regional pain syndrome, right? But in the brain for headache. So how does this guide our management, or rather reinforce those guidelines for management? Well, knowing that maybe a quarter to 30% of those with a chronic headache actually still have a partial CSF leak, it reinforces the idea that if there's only a partial or temporary response to the first blood patch, repeat the blood patch, right? And it also emphasizes the importance that if the headache is not getting any better or it's getting worse, you need to refer the person for a neurologic workup and proper consultation with the experts, and including imaging. All right, but let's get back to our patient, where the fun begins. So I saw her, Sunday morning before she went home, and it was that 91% of, patient doing well, going home. And then Monday, I get a call from Curtis, who's on labor and delivery. Actually, she hadn't gone home yet. It was Monday morning. She was going home, and Curtis went to see her before she went home. And he said that, he saw her before she went home, and they talked about some neck stiffness, but she more or less seemed okay. And I didn't necessarily have to call her, but he just wanted to let me know. Of course I'm going to call her, So I texted her, though, first, because I thought, well, she's got a newborn. They could be sleeping, whatever. I'm going to text first. So I texted, and I just spoke to my colleague Curtis. He said, your neck was still stiff, had a little achy, but he got the impression that you were still better. Did he relay the information accurately? Or more importantly, how are you doing? She writes back, hi, Dr. Maloney, all good over here. We headed home, just been getting settled. Being home seems to help a lot, so I'm just going to keep an eye on things for another few days. Okay, sounds good. I don't want to bug you, add to your burden of people you need to check in with, so please feel free to call me anytime with questions. Enjoy. So, yeah, it's going to happen. And then just because I'm a nagging pain in the ass, I repeat my my advice of what to do and not do, et cetera. And then give her my prognosis of what's going to happen over the next few days so she can know what to expect, a slow, steady improvement over the next 7 to 10 days, as long as she doesn't disrupt the patch. All right, good. Still in contact. Now it's Tuesday morning, the next day. Hi, Dr. Maloney. After a few reps of getting up with my daughter, I can now confirm it's the epidural headache. I'll follow the protocol for the next few days and make note of any changes or improvements. In the last day, I've had minor improvement in my neck mobility, but my hearing's a bit off. I sound like a robot underwater to myself, a little bit muffled. I'm also keeping an eye on my arms. They seem to have the nerve similarities to my neck, lower head responsiveness I'm feeling. So I write back, well, the muffled hearing is a less common but reported symptom. And actually, so, the great irony of all this is, a year ago when my daughter Lily had her spinal decompression surgery, a month later she had a delayed CSF leak that came on very suddenly, and she actually needed surgery to repair it. And Lily had hearing loss with hers as well. So I told her, keep drinking the fluids. The arm stiffness is more likely to be musculoskeletal, but keep relaying the symptoms to me. Looking back now, I was wrong. The arm symptoms were probably actually brachial plexus symptoms from cranial nerve traction. And I appreciate, said you're very internally attuned. And that was a nice way of putting that she feels every little thing, right? Because, she complained about the IV, was hurting her, the blood pressure cuff. She's a very internally highly wired person, for better or for worse. And I was optimistic that no return of the bad headache meant the patch was holding in some way and, repair work was going to go on. But you know what? I was kidding myself. By late afternoon, her headache was back. And hi there. It's actually her husband now that's contacting me. This is her husband. Do you mind if I give you a call some point tonight? The headache's barely improving. She woke up from a nap. She said it was 8 out of 10. I'm concerned this is more serious at this point, impacting some of the most important days of her life, which is quite sad and disheartening to me. And I hate to see her like this. I want to better understand what happened, how rare this is, other avenues we can seek, and what the risks of those avenues are. Very reasonable concerns, right? He's watching his wife suffer. I'm feeling like shit reading this, Oh, yes, please. Are you free now? I say she should come in for a second blood patch, and yeah, I'll be free in 15 minutes. I was in a case. I'll call you. We're very hesitant to do that at this point, but let's discuss. Call when free, thanks. Okay, so it's 4 p.m. on Tuesday. I call, we talk. They don't want to come in. So much going on. Caring for a newborn is so difficult. They're in Marin. They have to come all the way down. This is really traumatic for them. I don't know how to, I'm feeling a weird vibe, and I don't, he's irritated. He's clearly angry. Asking about, payment for the blood patch and stuff. Is he going to have to pay for another blood patch? No, we're not going to have to pay for another blood patch, He didn't pay for the first blood patch, So, I've been in practice now for a long time, and as I get older, the more confident I get, actually, in asking for help. It's the greatest thing you can do. When in doubt, phone a friend, right? So I checked in with Leslie. I called her. I just got off the phone with your patient, and I got a weird vibe, and, how make sense of her for me. And Leslie was helpful. Basically said, yeah, she's a little odd, but yeah, I don't really know the husband very well, yeah, she's a little odd. Yeah. Okay. So goes on, next day now, we're now 4 days after delivery. I get a call from Joel in the morning, can you call me? Yep, I call back, and we have a long conversation where, again, it's more about billing, and he's even more ticked off because he talked to his cousin, whose husband is an anesthesiologist, and the anesthesiologist's relative said, you never put in an epidural blood patch within 48 hours of a dural puncture. So I clearly had done the wrong thing, and why did I do that? And, if I'd waited, now they have to come back, and if it's been done, 48 hours after, during which time they actually still wouldn't have been in the hospital technically, but, they wouldn't have come back, and they wouldn't be having this problem. So I'm sorry, and I explained the rationale for why I did what I did and how they might have I told them at the time they might have had a second patch. Well, what is this article? Send me the article. Oh, okay, fine, I sent him the article, and I go on talking with him, that, I'm, this side is our continued text, I'm free now until 12:45, until my next case. If you want to talk more, so I sent him the article because I was in a spot a little bit later after our conversation, because I was in a spot that had bad Wi-Fi at the time of our conversation. She can come into either DPMC here, or if it's more convenient, she can go up to Novato and get the blood patch done at the ER there. That I'd contact Chris Schaefer, who was there at Novato as N1, and he could meet her in the ER, or, here in San Francisco, my colleague Peleg could come and meet her, and I'm trying to coordinate everything for them. I said, if you opt for a blood patch procedure today, please let me know what I can do to ensure that everything is handled as efficiently as possible. Hey, give us 10 minutes. We just got back from a doctor's appointment, and she's throwing up again, increasingly nervous. Something is more serious. Is this a common side effect? Would we have to wait in the standard ER, or would they take us right away? Yeah, nausea is a side effect of a post-dural puncture headache, but I'm getting concerned now. Throwing up, really. And the anesthesiologist would come, to be available in either situation as soon as they're available, because, there's other emergencies going on. And I cannot be any more specific than that, I explained. But if they let me know where they'll be, I'll try to coordinate as best I can. So he writes back, we need a moment. This is a remarkably difficult position to be in with a newborn, and we need to figure out logistics on our end with the no certainty on timing of how long we'll be there. Understandable, but at the same time, kind of, welcome to parenthood. Things happen out of your control, but this I caused. This is all my doing, right? And he's mad, and I feel awful, but I got to stay in contact. But phone a friend, right? Touch back bases with our other people. So I contact Marie, talk about how pissed off this guy is. She says, don't worry, they won't get charged for anything. At least we can take that anger issue away. Thank you, Marie. And he still hyperfixates on that. And I understand why he's hyperfixating on that, because it's the one thing he can control, right? He has no control over what's going on with his wife, and he's really upset and worried. And I contact Leslie again now, because I'm thinking, well, what if this is more than just a post-dural puncture headache? I actually decided at this point in my brain, she's coming here to CPMC San Francisco, where there's an OB department, and OB can come see her. And I talk and say to Leslie, I want an OB to come see her when she comes in. All right. So eventually negotiate that they are going to come in. And I talk to Peleg. I warn him. I say, hi, Peleg. Her husband should be in OB triage in the next 40 minutes. Please be your full force Menschy self. The husband is understandably very upset and angry. Okay, thanks. And so Peleg, updating me as it's all going on. She's here. I've walked by 4 times. She doesn't seem to be in distress. She wants to feed the baby, actually. Now the baby's gone potty, they have to change the baby. I'm being a little snarky and joking. Oh, yeah, she's not in distress, but her husband is, She won't let the nurses get vitals. I tell you, she's standing, walking around. I haven't seen her sit or recline. Like, yeah, that fits. And I don't mean that fits like she doesn't really have a headache. I mean, like, yeah, that fits. Something's weird. He was angry and upset that something was wrong, but panicked kind of. And why wasn't she ever talking to me? I never heard from her from like Tuesday morning onward, even though she's going to the doctor's appointments and walking around. So I was quite concerned. And I was worried, she felt twitchy to me. So, and she was twitchy during the blood patch. When Peleg and I did the blood patch, here's his note here. I'll let it speak for itself. She was calm and expressed understanding during this discussion. Her husband is understandably upset, but expressed understanding as well. He elected to leave the room for the procedure. You could literally see steam coming from his ears. Just before we started the procedure, the patient began to scream. We had not done anything yet. We all confirmed that we were not hurting her and nothing had changed. And she described this is just how she deals with stress and that she'd be screaming until we were done. And the procedure went smoothly. And there were no issues finding the epidural space. And but what Peleg doesn't describe is that when we then helped her lay supine, she panicked. There was something about the pressure of the blood in her back. And then in the laying supine, all of a sudden she felt like she was paralyzed and could not move her legs. And so when the husband returned to the room and she's lying flat, she's screaming. And so I gently at first passively move her legs and then, help encourage her. I say, well, it's probably, a little pain from the blood pressure and, it probably in spasm, but, take your time. First I had her wiggle her toes. She wasn't paralyzed. Then, okay, now move your ankles. When she felt she could do that, okay, now try bending your knee a little bit and she could move her legs. So that terror was gone. And, got her, dim the lights and got a damp towel for her forehead. And meanwhile, while I had drawn and I had Peleg do the patch because I knew I was freaked out. And I didn't want my anxiety to in any way affect my physical skill of doing the patch. And also, I wasn't sure how much confidence that she or her husband had in me. And I wanted them to feel like they were getting new hands, that I would be in front talking to them, I would hold her hand, I would draw the blood. And I made sure the nurses sent the blood off also for preeclampsia labs. And, I'd rest with her. Okay. So, the patch was done around 4, a little after 5. So this is me talking to Leslie now. I think she has a post-dural, I think that I told Leslie that, I think she has a post-dural puncture headache, but I think she also has preeclampsia. But And Leslie agreed. And then the labs came back, right? AST 134, ALT 259, and the first high blood pressure reading was when she was first lying down post blood patch. Maybe the first one was before she got the blood patch. Maybe we thought at the time, well, maybe she's in pain, she has a headache. But lying there still, they stayed high for the next hour and continued high until she got treated with nifedipine. So, she came in for an epidural blood patch, but she got admitted for IV magnesium. So let's go back now to the differential diagnosis of a post-dural puncture headache. There's a nice little handy mnemonic, PARTM, P for pressure, like blood pressure, like preeclampsia and eclampsia. A for anesthetic, like a post-dural puncture headache. R for reversible vasoconstrictive symptoms. T for thrombosis. U for usual. It could be just a cluster headache. It could be tension headache. Migraine. So it's important things to keep in mind. So let's talk for a second now about post-dural puncture headaches let's talk about postpartum preeclampsia, because that's what she presented with. So hypertension disorders of pregnancy happen in like 10 to 20% of U.S. pregnancies. But severe maternal morbidity is actually more common in the postpartum onset. Twice as common to have severe morbidity when there's a new onset postpartum hypertensive disease versus when the hypertensive disease is existent intrapartum. And most of the postpartum readmissions for seizure actually didn't have any prior hypertension in pregnancy. And yet the most common presenting symptom of preeclampsia in the postpartum period is headache. Now, why would this be? Because who the heck has a blood pressure cuff at home, right? How do you know you have high blood pressure? You don't. And, we discharge people from the hospital, and it typically occurs 2 to 7 days post-delivery, but women don't have their follow-up postpartum checks in a doctor's office until up to 6 weeks postpartum. So, meanwhile, 1 in 5 cases of eclampsia actually present postpartum. And for 10 to 15% of them, the presenting symptom is seizure because probably we never knew about the high blood pressure. And 30% of HELP develops postpartum. And there, it's going to present with nausea and vomiting and abdominal pain like she was having. And she actually relayed in retrospect, yeah, she actually had abdominal pain too. The most common presenting symptom is headache. And so we need to reorient ourselves to remember that when the postpartum nurses call us for a headache, it could be a post-dural puncture headache. And even if it's not a known dural puncture, we still could have had an unknown dural puncture. But if things don't fit, if it's not postural, something else is going on, don't just say, well, it's not me. Remember, you might be catching something very important. So now I want to talk about dealing with complications from a patient that we've harmed. And why is it so hard to talk about complications? So, very simple. Two emotions that I'm so very familiar with, guilt and fear, right? Why fear? Well, we have reason to be fearful. The fact is that the second leading cause of lawsuits against anesthesiologists in obstetric anesthesia is actually headache. The only thing that beats out headache is newborn death and brain damage, right? So, that's very serious. And so headache is really up there. Why do patients file lawsuits? A group at Baylor took a look at, interviewing a whole slew of patients. And patients expressed the following reasons: to prevent a similar bad thing from happening again, or to get an explanation as to how and why an injury actually happened, for financial compensation for the suffering or losses that they had, or to cover future costs because of what they suffered. hold doctors accountable for their actions. But behind all of these reasons also were unsatisfactory patient-physician communication. Patients reported that the physicians wouldn't listen. They wouldn't talk openly about what happened. They tried to mislead the patients. Patients felt deserted, where the physicians were unavailable. They devalued the patient's or the family's views. They didn't understand the patient's perspective. What information they did deliver, honestly, they delivered poorly. And they didn't warn the patients of possible long-term complications. So why is it so difficult to discuss these complications? Well, when an incident, and I'm going to leave the words because it was expressed so well by this Quality in Healthcare article. When incidents occurred, poor communication, perhaps an honest attempt to smooth things over, compounds the problem. We don't want to talk about the nitty-gritty of how bad it was, so we use kind of euphemisms. After Lily had her CSF leak, and in the final post-op visit after the second surgery, the PA said, well, we had a little hiccup there, didn't we? To my daughter, she spent her 18th birthday in an MRI for a headache that she couldn't sit up without crying about. It was more than a little hiccup for her, The second surgery meant that she couldn't dance in her winter concert because now she had an extended period of post-op healing. So in an attempt to smooth things over, compound the problem. Poor communication seems to distress the patient still more, may make litigation more likely, reduces the patient's trust in doctors and other health professionals. And her physicians did everything right, Looking more widely, we suggested that the medical staff find it very difficult to be supportive to a patient who's been injured by treatment that was meant to help them. When faced with an angry or grieving person, the natural tendency is to withdraw, as many patients reported that their physicians did. And let me tell you, I wanted to withdraw, right? It was angry. I had the good luck to speak with the woman. Actually, I texted her before this presentation, explaining that I was going to be giving this presentation, and would she be willing to talk with me and kind of debrief what happened and her experience and her husband's experience, because I wanted to be able to educate my colleagues. And she was actually up for it. I was very generous for her. And also very generous of her, she said, I really appreciated, she didn't really have anything she felt I could have done to make it better. She appreciated that I was very calm, and she said, it was really helpful how calm you were the whole time, and my husband was an asshole to you, and you stayed calm, and you didn't run away. You kept talking with us, and it's important to do because and it was uncomfortable for me, but I recognized that his anger was a response to unmet needs or expectations. He was expecting a wonderful new parent experience. He was expecting his wife to be healthy. She was suffering. And so, the most effective way to diffuse anger, as excruciating as it is, as difficult as it is to, remain silent and let the patient talk about the problem, to listen without interruption, to avoid becoming defensive, empathize, apologize that things didn't go the way the patient expected. You're not, admitting that you're a bad doctor by apologizing. Something bad happened, right? Ask questions, determine what they want, and explain what can be done and what can't be done. Talk about alternatives. All right, so now that's my take, right? But officially, the American College of Physicians and Ethics Manual says we need to, recognize the patient's frustration and possible fear. Recognize your own feelings of disappointment and anxiety, because it will affect how you behave, and you don't want to screw up the lines of communication. Don't panic. Keep the lines of communication open. Express regret, but avoid finding fault or blaming others. Don't tell the patient, well, if you hadn't moved, Explain what happened, proposed plan, and the proposed plan of action in terms that the patient can actually understand, and keep the patient and family informed and involved about the treatment plans and discussions, and document, of course, in the medical record. All right. So how should we discuss these risks beforehand, right? Because let's talk about informed consent here. This is a lovely quote from JAMA: a golden opportunity to enhance patient-physician rapport is lost if the physician does not take the time to go through all the elements of consent, which include explaining the procedure along the specific risks, possible complications, and alternate treatments available. Well, that's great, but really for the actively laboring patient, this is not feasible, right? My informed consent after I explain briefly what I'm going to do when I come in to do an epidural is the risks of an epidural are very low, but they're not zero. To put it in perspective, I had one for each of my 2 kids, and I know everything can go wrong about them. But I do teach a 2-hour class on this stuff every other month. So if you have any other questions and want a more full discussion, I'm here. We can go for it. And they always say, no, just please get me comfortable, because they're miserable, right? So this is my proposal. I think we need maybe something that we can do ahead of time. Maybe something that we give either to the OBs to distribute to their patients in the offices, or maybe when somebody first gets admitted to labor, although by then they're already in labor, maybe that's not so good. And it should probably be prettier than this, right? But I think it needs to have the following information, describing what an epidural does, that it makes your legs numb, that you'll still be able to move around in the bed, but you can't walk, and that you might not be able to get it if you've had a bleeding problem or problems with your back surgery. To talk about the benefits, excellent pain relief, fight or flight response is lowered, that you'll be awake, you don't get sedation. Okay, fine. Tell them the benefits. Yes. Tell them what's important to know, that the epidural is going to numb the nerves of their legs, they control movements, so they have to stay in bed, numbs the nerves of their bladder. I always go over this, but some people don't, right? Sometimes it gets bypassed, so they should know this ahead of time that they're going to get a Foley. And then we should talk to them on paper so they can read it and think about it, about the problems they might experience. Might not be in the right spot, might need to get replaced, might need to get medicine to treat blood pressure, might get mild itching, you're going to get a bruise where it was. Okay, all that's pretty minor stuff, right? We should talk about serious problems that can happen. They could get a headache. They get a headache, they might need treatment before they go home. It might not get completely fixed. They might have temporary nerve damage, might have medicine that makes it hard to breathe. And you can go over the very serious things that can happen. Because after it's happened, when they ask, well, why didn't you tell me this could happen beforehand? We don't really have an answer for that. So it's not as though, giving them something and having them sign it releases us from all responsibility. No, we need to absolutely stay in contact with people. It's our responsibility. We need to stay in contact and see them through. But I think it would be helpful for folks and helpful for us on the back end if folks came into the process more educated. That's why I've been doing the talks I've been doing. But I don't obviously get everybody attending, right? We deliver 4,000 to 5,000 women a year. Every session I get, maybe 50. 50 times 6, 300. I'm given a drop in the bucket. So this is my proposal, and I can send it to the group and the OB group, even if you think that'd be a good idea, Leslie.
I have a different proposal.
Oh, yeah.
Not that I wouldn't mind doing this, although I have to admit there's already a lot that we do have to give out during visits. I would propose that when patients are admitted, and if it's not an emergent situation where there are suddenly needed to be, treated immediately, that one of the anesthesiologists meets with them early on. If they have said, I am open to an epidural, then meeting with them beforehand, because usually you guys don't get involved until it's time for an epidural.
Right. And that has that does have some merit. I would say if we do that, we should probably still have something written to give them.
Oh, sure.
Because we're going to have different ways of expressing it. Some of us will be more easy about saying the nitty-gritty bad stuff that can happen than others. And it's not to have them sign anything and release us, but rather to give them all the information and then have them have the opportunity to ask us questions. Yeah, that's a very reasonable idea.
And I just want to add on that, and again, it's not that I don't mind giving it to them,
Yeah.
It's just that
They're inundated.
when I am presenting information that is not something that I'm actually
Right.
doing all the time,
Yeah, it totally makes sense.
gestalt that I don't have
Yes.
to add to it.
Right.
It's just like when I don't want patients, going to the internet and getting information there.
Exactly.
You're just not going to get that.
And supporting what you say about you already have so much information to give. One of the discussions I had with the woman after before this talk, was, she was really relieved in some ways that she had the post-dural puncture headache, because that's what led to her preeclampsia, getting picked up. And she said, yeah, I realize now, once I was in the hospital, I started reading all the stuff that they had given me to look out for when I was home. But of course, I was home and overwhelmed. I wasn't reading that stuff. So, she gets information about, if you have a headache, if you have nausea, if you have abdominal pain, call, because it could be the sign of something more serious. But she hadn't read any of that, because they are inundated. So perhaps someone contemplating an epidural there in the hospital might be motivated or have their partner read. All right. That's all I have to say. I said a ton. Does anybody have any questions from those on Zoom, if they're still there, or here?
Excellent talk.
All right. Thanks, everybody.
Thank you.
All right. Take care.